with that, we'll move to the next order of business, or really the first order of business, which is to approve the minutes of the September 10th, 2020 hospital board meeting. May I have a motion?
So moved.
Second.
Any discussion about the minutes, questions, revisions? We'll move to a vote then to approve. All in favor?
Aye.
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 Any opposed? Thank you. Dr. Adams, over to you for a report of the medical staff.
Good afternoon. Just a couple of quick things from a report from the president. I would like to, in this year of trials with COVID and all the stress that's gone on, we did manage to pull off a little bit of a celebration of years of service for our physicians. We did that in a very socially distanced setting, but we're able to do that. There were two remarkable individuals I'd just like to pull forward and point out to everyone. Dr. Clark McSparron celebrated 54 years of service, and Dr. Stephen Lockey, 50 years. He's been the chief of allergy and immunology for almost all 50 of those years. So just some tremendous contributions. We had several 30 and a few 40-years of service as well, and then down the line. So we were able to do that, fortunately. We were also able to celebrate some of the nursing units and all the good work they've been doing. It's been just very difficult to identify who has been the most pandemic hero out there because of all the extraordinary efforts that the nurses and staff have been doing, but we were able to recognize some of those. I think you're going to hear a COVID update later, so I'll spare those. I'll leave that to the future of the agenda here. But I would also like to move forward with some things that I need your approval for. If you looked at your packets, you would see that we have several documents that need to be approved. We made some revisions to the bylaws. As you know, this is a kind of a living document that we look at and at least twice a year do make some updates and revise. So there are a few revisions to the bylaws, to the rules and regs. And then if you look, you'll find 9 of the 10 department rules and regs coming forward. They were re-edited at the same time. There were small corrections that needed to be made, which were all made at the department level first, and then passed up through MedExec, and are now awaiting the approval of the board to put into practice. In addition to that, there was some more small revisions in the Division of Neurosurgery's clinical privileges in terms of call responsibilities that were spelled out. And then you'll also see in front of you there are guidelines for pediatric circumcision and frenotomy as well. And then from the Department of Surgery, from the Division of Urology, you'll see privileging for laser enucleation, and that was spelled out as well. So I am looking for a motion for approval of those, if I could get that. Yes.
So move.
Second.
Okay. And any discussion about any of those department rules and regs or guidelines that anybody would like to bring forward? If not, I appreciate a vote of support for those.
All in favor?
Of the motion, signify by saying aye.
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 Any opposed? The consent agenda passes.
Okay. And also, just to call out the med staff appointments that were in your packet as well. I think we need a vote to approve those, as well as the minutes that were attached for MedExec and the MedExec Executive Committee and credentials. So if I could have a motion.
So move.
Is there a second?
Second.
And
All in favor of the motion, signify by saying aye.
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 Any opposed? Thank you. The motion passes.
thank you.
like to confirm that the board members participating remotely are able to voice in. First of all, we've made a microphone adjustment because I understood that the initial discussion was muffled. Are you now, if you could just start with a thumbs up, can you understand and hear the dialogue? Thank you. And are you able to utilize your microphone to participate in the meeting? Yes, okay. Thank you. With that, we'll move to the quality update, led by Patrick Whalen.
Thank you, Mike. Can everybody hear me?
Yes.
Thumbs up? Okay, good. Well, as we round out the calendar year, I'd like to share some accolades for Lancaster General. And these findings come from high-profile publications, agencies, and organizations that annually rank hospitals throughout the country. And I thought it was good to present these findings at our board meeting today for the public and for our newer board members that came on this year. So, as you can see, LGH's quality performance on this slide puts us in the top 15% in Pennsylvania and the top 20% of all ACOs in the United States. And for almost 25,000 patients that we care for in this program, we have the second highest quality score in the region and deliver that performance at the lowest cost per year. And I'll ask you to look at the chart and note that the range in the annual costs to care for each Medicare patient from as high as $11,979 at Penn State Health to $10,128 at LGH. That's a difference of over $1,800 per beneficiary per year. And while the New York Times has previously noted that mergers of health systems have resulted in average price increases for admissions between 11% and 54% in the years following a consolidation, we've been able to continue to keep costs low here in Lancaster. And before we move on from this slide, I want to give a special word of praise to Kevin Bogary and Dr. John Wood, who shepherd our ACO, the Accountable Care Organization, here at Lancaster General. And then for our next slide, the Center for Medicare and Medicaid Innovation developed the Oncology Care Model, which aims to provide higher quality, more highly coordinated oncology at the same or lower cost to Medicare. Under the Oncology Care Model, physician practices enter into payment agreements that include financial and performance accountability for episodes of care surrounding chemotherapy administration to cancer patients. The practices participating in this OCM have committed to providing enhanced services to Medicare beneficiaries such as care coordination, navigation, and national treatment guidelines for care. And you can see the perfect score in the latest available data from 2019, 10 out of 10 and 50 out of 50. Notably, the patient experience score was in the 90th percentile or the top decile. And once again, I'd like to give noteworthy praise to Dr. Randy Oyer and Nick Boucher and the whole team who leads our effort at the Ann Barshinger Cancer Institute. And then the next slide. This is the U.S. News and World Report Best Hospitals Report. And as far as improvements from 2019 to 2020. Pennsylvania ranking, we moved up from number 7 to number 4. Orthopedics moved from number 47 to number 40. The number of high-performing specialties moved from 3 to 4, nephrology being the newest addition for us. The number of high-performing procedures moved from number 7 to number 9, with the aortic valve and heart bypass surgery being new. And then if we could look at the next slide, you can see on this with the rankings, LGH continues to perform well, very well, against its peers within the region and the state and the U.S. And the state. And you can see on the newest U.S. News Medicare Star Rating and the Leapfrog Survey, which assesses hospital performance on national measures, and those measures include safety, quality, efficiency on both the inpatient and the outpatient care. In addition to the U.S. News rankings that I discussed on the previous slide, as you can see from this table, LGH has a 5-star Medicare rating and a grade A from Leapfrog. In fact, we've had straight A's for the last 3 years from Leapfrog. If you could turn to the next slide. One thing I want to point out that's right underneath our name, Lancaster General Hospital, you can see we're one of only 13 hospitals in the country with all the following. And I'll talk about these in a snippet here. You can see we have a Medicare.gov Hospital Compare 5-star rating. And where does that come from? Medicare Hospital Compare has information about the quality of care at over 4,000 Medicare certified hospitals across the country. Measurements include process and outcome measures on patient experiences, timely and effective care, complications, readmissions, value of care, and patient deaths. The middle one, you can see America's 50 best hospitals by health grades. Health grades is based solely on clinical quality outcomes for 32 conditions and procedures. Patients are more likely without major complications and have a lower chance at health grades best hospitals. And America's 50 best hospitals are in the top 1% of the hospitals in the nation for consistently providing overall clinical excellence across the spectrum of conditions and procedures year over year. And the Leapfrog A score, where that comes from, is Leapfrog hospital safety grades are assigned to over 2,600 general acute hospitals across the nation annually, twice annually. The safety grade uses up to 28 national performance measures from Medicare, the Leapfrog Hospital Survey, and information from other supplemental data like the AHA, American Hospital Association. Taken together, those performances measures produce a single letter grade representing a hospital's overall performance in keeping patients safe from preventable harm and medical errors. So A being the highest score, we've had that 3 years in a row, and I just want you to look at that for a second and think about it. We're one of only 13 hospitals in the country with all these ratings. So I think it's a lot to give kudos to all of our people, and especially in this time of COVID for the heroes that have stepped up in this year that we've all lived through. So good things continue to happen at LGH, and these are the most recent quality scores that I want to celebrate with all of you at the end of this calendar year we're coming to. Any questions on that? Well, Mike, thanks for your time letting us provide this data today.
Thank you, Pat. And if I could just get a signification from the board, or Pat, if your mic is still off, were you able to hear my introduction regarding Charmaine Rochester, our new, soon-to-be joining the system Chief Financial Officer? Can you just give me an indication?
I did not hear that, Mike.
No.
I've heard that.
Okay, thank you all. I'm going to go back through that then because I think it's important. And so I started off the meeting by welcoming the newest member of the Penn Medicine Lancaster General Health Executive Staff. Charmaine Rochester will be our Chief Financial Officer starting next month. She is coming from within the Penn Medicine system. She was originally at she's coming to us from the Chester County Hospital, where she's been the Chief Financial Officer since 2017. Prior to that, she was Regional Chief Financial Officer at Bon Secours Hampton Roads facility in Suffolk, Virginia. So in total, she's had about 15 years of Chief Financial Officer responsibility at various levels within 2 health systems. She also has a Doctor of Health Administration from Central Michigan University, a Master's of Business Administration from Florida Atlantic University, and a Bachelor of Business Administration from Howard University. Charmaine is also a CPA registered here in Pennsylvania. We did need to approve Charmaine as a new officer of the organization. Typically, we approve the officers at one time during the year because they're typically in place. but as a newly joining officer, we need to go through that. So I'm going to go through the motion again because I think we wound up having a vote within the room, but not within the full board. So I will again ask for a motion to approve Charmaine Rochester as the Chief Financial Officer for Penn Medicine Lancaster General Health.
So moved.
Second?
Second.
All right. Any questions or discussion? Move to a vote then. All in favor of the motion, say aye. Aye. Any opposed? Wonderful. The motion passes. You'll look forward to meeting Charmaine. I've had the pleasure of meeting her through the recruiting process. She's a wonderfully talented executive, and I look forward to many years of excellent service for our organization. And we're also very, very pleased that Joe will stay on and help transition for several weeks through the end of the year. And, being Joe, I'm sure we'll be there as needed to lend a hand as Charmaine comes on board. So we're excited about this development. And of course, we warmly welcome Charmaine into the organization.
Hey, Mike,
Yes.
it's Katie. I just had a question. Are we going, I know we have COVID going on about not being together. Are we going to do some type of reception to welcome her to this at some point? I was just wondering.
I'll turn it over to Jan, but I will say in the context of COVID, we're obviously going to be very sensitive about how we would do that. But we certainly will want to make efforts to ensure that she gets to know the board and is welcomed into the organization. Jan, I don't know if you have anything to add.
Yeah, I'll just add, can you hear me?
Yes.
Thank you. We have to take a very untraditional approach. We are going to be relying a lot on a very, very extensive onboarding where she'll have the opportunity to spend time one-to-one with a lot of people, including board members, rather than doing a traditional kind of welcome reception. It's just really impossible to do that today with where things stand with COVID. So hopefully as we get into the arrival of the vaccine and are feeling better in the spring, we can even revisit doing something at that point. But right now, we're really planning on using our onboarding, a lot of one-on-one discussions as a way to introduce her to the organization.
Perfect. Thank you.
Yeah, thank you for that
Question, Katie. I also want to make sure that we have appropriate approval of the minutes, since that may have been muffled in my introduction without a mic, I guess. So I will look for a motion to approve the minutes of the September 10th hospital board meeting.
So move.
Is there a second? Any questions or revisions to the minutes? If not, we'll move to a vote. All in favor of passing the minutes signify by saying aye.
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 Any opposed? Okay, the minutes are passed. Thank you all very much, and I apologize for any of the confusion that may have occurred up front as the microphone was struggling. The other thing that I announced was that we will be wearing masks due to the new mandate at the state level. And ironically, was talking about the fact that we'll work very hard to speak loudly and articulate, despite the fact that we have masks on, so that you all are able to hear what you need to hear to effectively participate. To the extent, as we go through the meeting, you have any difficulty hearing, please jump in right away and just say, hey, we can't hear you, and we will do our best to make adjustments. So with that, Joe, I think we'll turn it over to you for the hospital financial update.
Good afternoon, and I'm sure that you can all hear me. Good, thank you. I'd like to extend my personal congratulations to Charmaine. I am very excited for the organization, and I look forward to helping her transition forward as we go through the rest of this calendar year. I'm excited for her, and I'm excited for all of you, and I personally want to thank all of you for the opportunities that I have had over the many decades that I've been with Lancaster General. What I'd like to talk to you about, excuse me, I'm getting ahead of myself, is the impact that the COVID
has had on demand for the hospital for the first 4 months. We have seen something that was highly unusual with respect to demand, service mix, payer mix, the split between inpatient and outpatient services. Traditionally, we would have believed that the inpatient business that we experience and the inpatient market share that we have was the key driver for us financially. And without a doubt, it still is, but we have experienced in the period of COVID a rapid decline in our elective business and a fall off in some of the inpatient business was being deferred. And what's happening is a set of demands and a set of mix of services that has changed our typical thinking. You can see on the slide that you can see how far behind we are after 4 months on the inpatient caseload. We are 1,000 cases behind, and that would usually have been, if anything, a bad annual number. But in 4 months, we were 1,000 inpatient cases behind, and you can see it's 8.6%. And this is through October. It is not reflective of the activities that are happening in November around the current COVID demand. Likewise, the observation cases are down significantly, 12%. And you can see it's affecting all payer mixes, with the biggest impact being seen with Medicare population. But an equally important piece to us is the commercial component. Surgery cases trail by over 700, 5% of our business of their business at this point, and inpatient is significantly down 600. Usually we see the inpatient business decline being made up on the outpatient side. We believe a lot of that casework is being deferred, and you can see even our joint venture business is down 140 cases. I'm having a little trouble with the machine. It will not, there we go. Other key services that are down significantly are the emergency department. Since July, you can see it's still down 7,500 visits. 40% of that is the main, what we call the main ED, and 60% of that amount is fast care. And the fast care demand drop in comparison down below, 2 lines down with the urgent care, is not inconsistent with what we're seeing throughout our system, that these lower level services, for various reasons that others could explain significantly what that would be, is down. Trauma activation, however, is flat, up a little bit, 11 cases. And overall, the professional visits are down 13,000. Outpatient services, this is where we see the big difference. Outpatient business is up dramatically, 14,000 visits on a base of 400,000 visits. And cardiovascular is up 6%. Radiology is trailing by 6%, but laboratory work is up 37,000 visits. And even what's interesting, throughout all the COVID activity, from whether it would be starting in March or just starting in July, our infusion business has held very strong and consistent, along with radiation oncology. So the payer mix change has been dramatic, as I showed you on one of the first slides. The split between inpatient and outpatient business has changed. We were heavily an outpatient operation in the recovery phase of COVID. That is now falling back to almost normal levels of 51-49, 51 outpatient, 49 inpatient. It was as high as 57 outpatient at one point. But as the inpatient business has come back up in September and October, and now significantly in November, I'm convinced it's going to return to the normal levels of around 51 to 52%. Despite all those changes, the payer mix changes, the split between inpatient and outpatient, and the change in service mix, price-adjusted revenues are merely 2%. Actually, it's 1.8% behind the prior year. So from a financial performance set of metrics, the operating margin is consistent and slightly ahead of last year at this time at around 4.7%. And we think that this has been actually a very interesting learning experience to go through financially, because we have not seen this set of inputs on our business before. With that, I would take any questions.
Questions for Joe?
Thank you.
Okay, thank you, Joe. We'll now move on to our presentation of Penn Medicine Lancaster General Health's COVID-19 response. Gianna, are you going to kick us off? Thank you.
First of all, just a warm welcome to everybody that is joining us for the open board meeting. Thank you for taking the time to learn more about Lancaster General Health. We're going to focus this afternoon as a presentation on COVID, clearly with COVID dominating the work of the organization for the past 9 months and the significant rise in the number of people in our community that have tested positive in the last month. We thought it appropriate to take some dedicated time this afternoon to talk about our past experience, our present experience, and also to talk a little bit about future implications of the pandemic. Before we move into the actual formal presentations, though, there are a few things that I wanted to share as part of my opening comments. First of all, on Tuesday of this week, we received communication, all of the CEOs of licensed hospitals across Pennsylvania received a memorandum from Secretary Levine at the Department of Health. And this was communication from her with the governor's blessing, providing new guidance to hospitals in terms of the handling of COVID. She indicated in her memorandum that based on the modeling data that they're using from the Institute of Health Metrics and Evaluation, they are anticipating that in December, Pennsylvania is going to reach peak levels of COVID activity. And their concern is that this is going to put particular pressure on hospitals, and within hospitals, specifically ICUs. It was heartwarming to me that they decided not to put into place mandatory closing of elective procedures or elective health care as they did in the spring. What instead they have taken as the approach is that they are looking to hold hospitals accountable, as I think we hold ourselves, for basically balancing the load of activity that we are seeing in our respective organizations. And that is very consistent with what we have been doing over the last couple of weeks, and we can share more with you as we go on through this afternoon board meetings. The Secretary's guidance also reflected the approach that I think other states are using. There was reference to the collaboration and coordination going on between states in the Northeast, which is heartwarming as well, recognizing that people move between states frequently and that we are not an island in and of ourselves. One of the things that was referenced in the communication was that there's no question that citizens in general are having pandemic burnout. And they go on to also reference and to recognize, which I found very important, that they know particularly that healthcare workers are understandably experiencing this dynamic. And it is in that spirit that I want to ask you, as we go through the presentation this afternoon, to remember that as you look at the data that we're going to share with you, every death, every person who has been hospitalized represents a friend, represents a loved one, represents a neighbor. We all get numbed by the numbers, and we can fall into forgetting the toll that the pandemic is having on society and this country overall. And at the same time, I ask you to think about the burden that the pandemic has placed on our workforce and our providers. We have been in this fight for 9 months, and we know we have many more months to come. I recently received from Larry Strasner, our chief nursing executive, it's not a poem, but it's a written narrative by a young nurse who shared her experience with COVID, and I'm going to share it with you this afternoon. I hope you'll forgive me if I take 2 minutes to share this with you, but I think it's really beautifully written. It starts, "When a superhero fails, I walked past the door, knowing who or was hidden behind it. I watched the other heroes put on their protective shields and take turns quietly slipping in the room. The silence of the room was punctuated only by his gasping for breath. Hours would pass, but I kept watch, Putting on my own suit of armor and tending to the tasks of helping others struggling to complete even the smallest of movements. Just breathing was so hard. I felt the touch of the warm cloth as I wiped my patients' faces, which must have felt suffocating instead of healing. But that room on the other side of the hall, I needed to go there. I needed to face what the end looked like. I had seen it so many times over, that ending. However, this one was not the same, and I knew it. I slipped in that room, covered in my hero suit, as I sat beside the human in the bed who was gasping for air. I touched his hair softly and held his hand. I closed my eyes and said the Lord's Prayer. I did not know him, did I? I thought about his life, who he was, who he loved. Why did he have to meet God in this way? I was angry. I was sad, but I was grateful all at once. And I was humbled. I was gifted because of the opportunity to be one of the very few to let this human know they were not dying alone. He would not die forgotten, even as he faced an ending no one should. Agonizing that despite all my superhero gear and armed with all my superhero compassion, I could not change his fate. I could not stop COVID-19 from slowly stealing the life of that human. Admitting that we as nurses are not superheroes, I prayed God would take him softly. We are just humans, all deserving of someone to be there when the end comes. The ending of the story is only mine now, but the lesson is for us all. Forgive more, appreciate the small things, live every day like it was your last. Be grateful for the moments God asks you to step up and be a superhero, but know we all fail sometimes. The gift is in trying, not in the ending. So as you move into this holiday season, particularly Thanksgiving, please make wise choices. Mask up, wash your hands frequently, keep safe distances from others, and please limit your contacts to those who are in your own family bubble. Do it for yourself, do it for your family, and please do it for our workforce. Thank you. Mike?
And thank you, Jen. I am incredibly grateful for our workforce as well. In echoing your comments, it is a difficult time for all of us, but we thought it was important today to reflect on the past of where we have been during this pandemic, but also talk about the present and future. So let me start with a little bit on the past for our conversation this afternoon, and particularly around this first graph. Not to go through the details, but as you can see, almost a 300% increase in cases in the last 3 weeks in Lancaster County, much higher than where we were in the April and May timeframe to the left of this slide. And if you follow that light green line for the county, you can see where we are at almost 400,000 cases per 100,000 as of last Monday. Let's remind everybody of the community commitment that we have had in responding to this pandemic. And I wanted to outline 6 items that we've done so far since we started really planning this work in January of 2020. It seems like many years at this point. I'll talk about the healthcare strategies that we put in place early on, our public health leadership on testing and contact tracing for the county, supporting our unique communities, our post-acute partners, as well as our employers and the school districts. So I'll start with our work around mitigation strategies. We did start this work probably with Dr. Contra's leadership and a small team in January of this past year. And it was really predicated on the framework from the Centers for Disease Control around limiting people entering the system, limiting exposures once in the system, and of course, reducing demand on our scarce resources. So I thought it'd be important to remember a few things that we did there, like shifting our workforce to remote. In order to work every day. Almost 1,200 were shifted to remote work. We talked about self-quarantining for travel. We put things in place like our testing centers, visitation policies, and use telehealth as opportunities to really limit those who would need our services and then try to provide those during the early months of the pandemic. Second, around limiting exposures once in the system. Really critically important as I'm wearing face masks, and we're reminded that it is the most important infection control measure we can do to limit exposure, to wash our hands and socially distanced. but also we did frequent deep cleaning of our areas across the system according to guidelines, and obviously protecting our staff and employees with personal protective equipment. We reconfigured spaces to allow for social distancing in our facilities. We put symptom screening in place at our front entrances, and we created dedicated COVID-19 units for care of those patients. And then finally, reducing demand on our scarce resources. Medical supplies, pharmaceutical supplies, critically important for us. And we put plans in place early on so that when the pandemic waned a little bit a few months ago, we continued to buy our full allocation from the vendors in order to have the supplies to continue our care for patients in the community. It's critically important for us to maintain both those PPE supplies as well as pharmaceuticals so we can continue the treatment. Next, responding to the pandemic. Obviously, you saw visual indications of that with our 10 testing sites, with our outreach from the community, with connections and coordination in terms of educational materials and outreach on Zoom, as we've all learned and seen over time. So we set up those tents at the PA College, remember, and also at Clipper Magazine Stadium. We followed that effort by really starting a community-wide tracing and testing effort with Lancaster Health Center and WellSpan Ephrata. That gave us a real comprehensive, unprecedented public health effort to really respond to the first wave. And I think the lessons we learned during that first wave are really helping us as we prepare and really address this third wave we're facing now. This is a reminder about contact tracing. We've been able to really exceed benchmarks up until the last several weeks in terms of reaching out to those cases. And I just met with our contact tracing and case investigating team this afternoon at lunchtime, really expressing my gratitude for all the work that they're doing and really stepping up with additional hours overtime to keep up with the surge of cases that we've had in the last several weeks. So I appreciate all of their help as we continue to address the work across the county. We were supporting unique communities during this beginning months. We took a population health approach. That's the same approach we take if we're going to care for our diabetic patients, our patients with heart failure. Patients with COVID-19 not only have short-term needs that may progress to hospitalization, but as we're realizing and seeing in the news, patients with COVID-19 will have long-term effects potentially as well. And it's critically important for us to use those same tools we use today to care for our heart failure patients and our diabetics that we would care longitudinally for patients who have had COVID-19. With Dr. Fife's leadership on the Lancaster City Board of Health and our thanks to the mayor's office, we were really able to do some outreach to the city as well as our further communities in the periphery of the county with the parochial center and the work with Dr. Rehart, Dr. Martin, and Alice Yoder with our Amish Safety Committee as well. Another big piece is around post-acute care and supporting our post-acute partners. Penn Medicine partnered with Temple to participate in a state grant program called the Regional Response Health Collaborative Program. And this RICP program really enabled us to provide that clinical support and counsel to more than 80 skilled nursing facilities, representing almost over 2,000 residents that we're taking care of. And this team, while small and mighty in Lancaster County, has been able to do some amazing things, like 24-hour call center access, rapid response teams. In fact, several of our team members responded to one facility and were able to work overnight shifts in that facility to make sure that the care that was needed during an outbreak was provided to those residents and the staff who work in that facility. We've been able to help with instruction around COVID testing, infection control, personal protective equipment, and as well as having specialty physician access to our infection control team, our geriatricians. And finally, and maybe most importantly, it's staff and resident morale support and grief counseling for those that have passed. We also have been able to support the employers in the community. With our work around the HealthWorks team, we've been able to kick COVID together by putting tools and resources in place to protect our workers, decrease stress, and build resilience. You can see some of the work that they put together in terms of educational handouts and outreach to our business leaders. And then finally, our support to the school districts. My personal appreciation to Dr. Jeff Martin, our Chair of Family and Community Medicine, for all the work he's been doing on the webinars, support for the school district superintendents in support with Alice Yoder and her team and the community health team. We've been doing many things in terms of research-based guidance, as you can see on this slide, as well as expert advice on demand. Dr. Martin's constantly taking calls and questions from all the communities and school districts. We're supporting them with webinars. We've been able to support some of the school district board members as well with information on how to approach our current surge. It's been an amazing opportunity to see the collaboration and coordination occur across all of our county in all of these areas, whether it's post-acute, our employers, as well as our school districts. So let me segue now to Dr. Contra, who will come up and give us an appreciation for where we are in the current state. Dr. Contra.
Thank you, Rip, and good afternoon to everyone. I appreciate the opportunity to provide an update for where we are on COVID-19. We'll start out with a sort of a micro view of Lancaster County. This chart shows Lancaster County cases. In the past 7 days, you see we've now reached over 1,000 cases in the last week. The prior week we were at 775, and the week before that we were in the 560 range. So at this point, clearly we are entering the upswing of the third wave of the COVID pandemic here in Lancaster County, as is happening across the United States. And I'm sure, as all of you know, if you've been watching the news, this particular rise, this particular wave of COVID is steeper and will likely be a lot higher in magnitude than the other two previous ones. Our testing here in Lancaster County has accelerated quite a bit. This is a graph that shows our testing volumes in the blue bars, the moving average in the yellow. And if you look closely at the bottom, there are some teal bars that represent the number of positive cases. As you can see, our percentage of positive tests has risen to about 9.1% in the last week, up from 6.4% the week before. But if you break out those individuals who are symptomatic, those who have cough and fever, our positive rate is up towards 20%. And if you look at our healthcare workers who are exposed, typically in the community, their positive rate is approaching 30%. So clearly it's rising on all fronts. The other point I'd make about this slide is that you notice the magnitude of the blue bars going from left to right. You can see that our testing capacity at LG has increased quite a bit during the course of the pandemic. And that is owed to much extent to a collaboration between our lab and the Pepper Lab downtown, who have provided us with a lot of guidance and, in fact, a fair amount of direct support. This is a graph looking at our hospitalizations, and as you can see, our wave in the spring was quite impressive. We did calm things down over the summer. We had a couple of micro blips around the holidays. And we thought in the middle part of September, like we may be in for a nice, slow, low tail heading into respiratory virus season here in the fall. But unfortunately, since the end of September, we've had a quite steady rise in cases and hospitalizations. And as you can see now, we've exceeded the number of hospitalizations that we had in the spring. So just a bit about our therapeutic options. Those have come a long way as well. During our pandemic response. We now have several pharmaceuticals which have been shown by randomized controlled trials to be effective. Remdesivir is the antiviral medication which inhibits but does not kill the virus, and dexamethasone is a steroid medication which is used for patients who are experiencing what is referred to as an inflammatory storm, that phase of the viral infection where the host immune response becomes damaging rather than beneficial. We also have some immunotherapy options. Convalescent plasma is in use here at LGH. We actually did have 120 units a couple of weeks ago. We're now down to about 90. But we continue to have a robust donation program here in Lancaster County, and we're hopefully going to be able to continue to far exceed our utilization. Plasma is used fairly heavily under an investigational protocol at this point. And we have recently the addition of some monoclonal antibodies. Regeneron, of course, the drug that the president got when he was ill with COVID, is still under compassionate use, which means you apply for it one patient at a time. The time to get the drug is longer than we'd like it to be, but we now have an Eli Lilly agent that's out by FDA EUA. We've not received a allocation of this yet, but we hope to have it soon. The unique thing about this drug is that it is for outpatient use. And so up to this point, our therapeutics have really been concentrated on those sick enough to be admitted to the hospital. This new drug from Eli Lilly, however, will be able to be and has to be used on the outpatient side. And basically, we will try and work out a mechanism to identify patients who are COVID positive, perhaps who have elevated risk factors, and try and get that drug to them to prevent hospitalization, which this drug has been shown to be able to do. We've also, along the way, with the work of our critical care teams and our pulmonologists, developed approaches and techniques to help avoid ventilator dependency of our patients. High-flow oxygen therapy, such as vapotherm, has been used now for several months and has been quite beneficial. We've had an association with the Penn Medicine Critical Care Alliance as well, and this is one of several areas of interface that we've had. We have an infection control interface looking at infection in CLABSIs, catheter-associated bloodstream infections. And we've also had a connection with the Penn Critical Care Alliance in terms of sepsis management. And now this is our third approach with COVID management as well. So we've been very appreciative of that association, and I think we'll continue to make progress. And of course, the hot topic is now the vaccines. So I just wanted to briefly talk about those. There are really over 200 vaccines that are under study. And Operation Warp Speed was designed by the federal government to provide financial assistance to drug companies to develop these drugs and distribute them, basically taking the financial risk away from the pharmaceutical companies. And in fact, there are 11 vaccines in large-scale phase 3 trials at this point, but the two that have approached the finish line first are the ones that are mentioned here, the Pfizer vaccine, which was announced on November 9th, and the Moderna vaccine, which was announced by press release on November 16th. And we just want to take a moment to appreciate what's been accomplished here. Both of these vaccines are messenger RNA vaccines, and for those of you who aren't biochemists, suffice to say that this is a novel approach to vaccine making in the world. It's not been done before, and it's really based, and Penn has a particular reason to be proud of this, a lot of the frontline biochemistry and molecular biology that was done on this was done in Drew Weissman's lab at Penn, probably a dozen years or so ago. This is coming to fruition now, not only in these two vaccines, but also in other potentially therapeutic applications for respiratory illnesses and even sickle cell disease. So something to be very proud of. Both of these vaccines also are highly effective. I think vaccinologists, when these vaccines were being developed, were sort of cautiously optimistic, saying, well, maybe if we get to 70%, we'll do well. Both of these vaccines are more than 90% effective. Pfizer said greater than 90%, and Moderna said, well, we have 94.5, and then Pfizer came back and said, well, we have 95. But suffice to say that they're all very effective. And this then represents a real potential to begin to turn down this epidemic, this pandemic across the world by the use of vaccination. Make no mistake, there are many, many hurdles to get over to be able to distribute these vaccines. There are cold storage requirements for both that are considerable. And the whole concept of getting a therapeutic but emergency use authorized vaccine out to large populations will certainly be challenging. But there are our task force that work here at LGH and, of course, in the Penn system, and we hope to be able to get this up and running. Vaccine is expected to be available sometime in the next few weeks, actually by mid-December is most of the projections. So we're very excited about this. This is sort of the holy grail to have a vaccine that is highly effective and safe, and these two vaccines appear to fit that bill quite nicely. And I just wanted to show this slide about the proposed vaccine distribution rollout. This will not occur in one fell swoop. It will occur over many months. Phase 1, as you see on the right side at the top, the jumpstart phase is really what we're concentrating on at this point, because that involves a vaccination of high-risk healthcare workers, those who work in COVID units, in the emergency department, in labor and delivery, those who perform high-risk aerosol-generating procedures, among others. And we are in the process, both here locally and in collaboration with a system task force downtown, to try and prioritize how these groups are identified, survey them to see what their vaccination likelihood of receiving the vaccine or accepting it will be, and then finally getting it done. I mentioned the cold storage requirement. The Pfizer vaccine is required to be stored at minus 80 degrees centigrade, which is quite challenging. But once it is thawed, you have a relatively short time to get the vaccinations done. So the logistics of getting many, many healthcare workers vaccinated will be challenging. In addition, we don't know at this point how many doses of vaccine we're going to get. So it's a matter of creating tiers and contingency plans depending on exactly what we get in terms of vaccine supply. But once we get through phase 1 into phase 1B, then we're looking at high-risk individuals in congregate living settings, high-risk individuals subsequently in the community. And we have to look at our large panel of patients that we have responsibility for and begin to, again, create tiers and levels at which we will begin to distribute the vaccine. In phase 2, we're looking at teachers, critical workers outside the hospital, and a number of others. Getting into phase 3 and 4 will really be probably next spring and summer. But again, by that time, we'll have some additional vaccines. There are 2 other vaccine candidates that are likely to come out probably in April and May. And once those are out, we'll have quite a number of options to move to. So I just wanted to say that this will be a challenging winter, to say the least. But I look on the bright side in that we have now had 8 months of experience with dealing with COVID, and even a couple of more months if you consider the planning that we've done. Our diagnostic capabilities are far more robust than they were in the beginning. Our therapeutics are now present, where we didn't have any in the very beginning of this. And we have a vaccine around the corner. So I'm optimistic, despite the fact that we're on a steep climb, that we can get this under control. And hopefully, particularly with the vaccination program, we could begin to turn off the pandemic. So with that, I'll take any questions.
I have a question. This is Kim Smith. I'm not sure if you can hear me. Can you hear me?
Yes.
Okay. Regarding the vaccine, is it a once-in-a-lifetime vaccine, or is it an annual shot similar to a flu shot?
Well, that's a great question. So the vaccine, the 2 vaccines that I mentioned, the Pfizer and the Moderna, are both 2-dose vaccines for the initial round. It is not known at this point, because the study of these vaccines has only been going on since the end of July, whether subsequent vaccinations in subsequent years will be necessary. I think one prediction that's very likely to be true, however, is that this vaccine will be very unlikely to be like the flu, and that the mutations that are involved in influenza are fairly unique, and I suspect that it will be more a matter of how many years can we go between doses, more so than having to create a new vaccine every year.
Right. Thank you.
I have a question, if I could.
Sure.
Thank you, Doctor, first of all, for that presentation. Much appreciated. One of the early concerns about the whole effort was the point at which hospitals were going to be overrun. And I watched this, I see this spike on the charts that you were sharing with us, and maybe Jan's going to address that next. But where are we in that sense?
Well, this is a somewhat different situation than we were in the spring. In the spring, as you know, we shut down elective procedures. We opened up our hospital for beds, anticipating essentially a tsunami of cases. We were able to avoid that, and now we're in a different situation where we have rising cases, but at the same time, we've stocked up on PPE, and there are a number of contingency plans in the works. And Jan, would you like to address those, or shall I?
Oh, no, go ahead. If you're on a roll, go for it.
Okay. So, in essence, remember, all hospitals had contingency plans for what happens when our ICUs become overrun. Where do we get the extra ventilators? Where do ventilator patients go when our ICUs are full? We have all those contingency plans in place. What we're hoping to do as we go through this surge of cases is to work in a balance. We hope to be able to maintain a fairly high hospital census, maintain as much of our normal flow of hospital inpatients and services as we have in the past, and at the same time continue to take on the COVID cases that come on. There are some unique features of this particular wave, and actually the waves over the summer as well. We know that the age of patients who are coming into our hospital are now about 15 years younger than the average age at the beginning of the pandemic. We also know that hospitalization rates as a percentage of those who are infected are lower than they were before. And I think we have some advantages that we didn't have in the spring. So again, it's going to be a day-by-day decision. Our leadership here at LGH is ready to deal with this, and we are speaking several times a day, every day, about how to approach this and where we are right now in the pandemic. Thank you.
Tom, I'll pick up and add one additional comment to the great response that Joe provided. Part of looking at this every day, multiple times a day, is not just forecasting inpatient utilization and what beds we're going to need available to care for our surgical patients and our COVID patients, and just patients that are normally requiring an inpatient hospitalization. But one of the biggest factors we are facing right now is dealing with staffing based on the high percentage of people that are out from the workforce and being quarantined. We are seeing days where we have 19, 20 of our staff that test positive. We've had over 200 people a day out quarantined. This is having a huge impact on our ability to be able to respond to the demand for our services. So as Joe said, and I'm going to underscore, it is multiple times a day that we are looking forward at staffing, at surgical schedules, and making adjustments as needed with elective procedures. We're looking at the ED volume and what we can anticipate in terms of inpatient requirements as a result of that, and literally load balancing throughout the day. And I'm deeply appreciative to all of the leaders, our physician leaders and our administrative leaders that are working on those things every day. But being able to have the workforce to be able to accommodate this surge is a significant challenge, particularly, as I said before, burnout is definitely a factor. People are tired. And that is not unique to us. It's happening, throughout the nation. And so it's just something we have to continue to address. I'm going to see if this works. Oh, nope, wrong way. I'm just going to take a minute since it's 2 o'clock. I'm just going to take a minute to go through, I think, some of the forward-thinking strategies and ideas that we have. First and foremost, one of the things that has been just an absolute essential learning for us is that there's no question that a public health emergency requires a strong formalized community response. And there are 4 levels of an effective community response that we focus on. The first is around personal preparedness. And part of that is educating the public as to what they can do to protect themselves, and to also to create public policy that enforces those things that from a personal level are absolutely essential for someone to do. The second is around planning. And one of the things that has been very clear to us over the last 9 months is that if we hadn't already had pre-existing, well thought out, well-honed emergency preparation plans, we would have been at a just tremendous disadvantage. And so having the ability to continuously evaluate, modify, and improve those plans is essential for part of our future preparation for anything that comes our way. Third is around policy and partnerships. And we tend to think about partnerships as being within the healthcare community. Those are important. There's no question about it. Coordinating between the various different healthcare providers, from post-acute to home care, through all the various different hospitals in a market, is important. But it's partnerships with schools, it's partnerships with employers, it's partnerships with elected officials, with the state. All of them are essential. And the fourth is around public health policy and response, and that's an ongoing area that we have spent a lot more time than I would have ever anticipated that we would have to spend time on. In terms of preparedness, as I said, the continuous updating and and taking what we learn and putting it into the written plans that we have so that we can utilize that going forward is really important. One of the other things that is very clear in terms of future preparedness and this process of always being prepared for anything that comes our way has been in the area of supply chain. I think we have never experienced before a national breakdown in the supply chain of equipment and supplies that we need to be able to serve our community. And so that changes your thinking about inventory control and how you approach the supply management. And so we are putting some of these changing practices into place. The other thing that is really important for us is we've recognized that there are many other types of roles that experts in our organization can do in the face of an emergency. Staff on the ambulatory side can work in an inpatient environment if they have appropriate training and tools and mentors and facilitators. And we've learned a lot about that. But how do we keep continuously prepared for another emergency with that the amount of work that is involved in doing that? You have to maintain deep data around who has what skills and where are they. And then you also have to think about ways in which you can continuously refresh their learning so that they don't lose what that they were able to essentially learn through the pandemic. How to support the psychological and emotional needs of the workforce, and things like daycare. When schools close and all of a sudden we have a significant percentage of our workforce that can't come to work because they have nobody to provide support to their children at home. These are not things we've dealt with before that are all being incorporated into our plans going forward. So as we look to the future, we're also thinking about what have we learned about the way in which that we provide care. And there's no question, we all know it. There was a lot of work that had to happen overnight in terms of how we transform care, particularly on the ambulatory side. So we literally, in 48 hours, were able to offer at first, it was not video conferencing through the Zooms and Blue Jeans and all of those tools. It was phone conferencing, but we were able to move to virtual platforms in 48 hours once elective care was shut down. We've learned a lot about that, and in fact, we've moved from that initial stage to what we call telehealth 1.0 to telehealth 2.0, which is just continual enhancements. But we also learned that we have gaps in all the services that we provide, that there are new, more contemporary models of care that can be a combination of in-person and virtual care that can really enhance what we're able to provide. And many of those new models and emerging models have the ability to both work in a pandemic or a public health emergency as well as work under normal operations. So we continue with our innovation team to look very closely at that. So there's no question that we have to continuously continue to work on preparedness. We are not of the belief that we will not have another pandemic for 100 years. We have to be prepared that we may be facing this again in the near term. The other thing is that there's no question, as you all know well, that in our community, a formalized community response is difficult without a public health department. That has been incorporated as an initiative into our strategic plan in recognition of how absolutely essential it is. And then I think the third just kind of closing comment I'd say is that we had no idea how difficult it would be to get people to comply with the basic public health measures that are in their best interest. And just the political nature of what's going on in our country today and how that has impacted compliance has made this very, very challenging. But we've learned a lot about public education and what we need to do in terms of repetitive messaging to try to get compliance. And all of those things are being incorporated into our plans. So we're hoping this afternoon's presentation was a helpful look back, a view at what we're dealing with today and some of what we have to look forward to into the future. And happy for any of us to take questions.
Thank you, Jan. And so I will look back to the board here and remotely for any follow-up questions to Jan's presentation. Not seeing any, Jan. Dr. Ripchimsky, Dr. Contra, I do want to thank you, first of all, for that excellent presentation and update, but more importantly, for the work you're doing every day to enable our community to get through this in the best possible way under the circumstances. The work that you're doing is remarkable, and it is greatly, greatly appreciated. Thank you. With that, I'll just do a check on whether we have any hospital old business or new business to introduce to the agenda. Seeing none, we will go ahead and adjourn the hospital meeting. I would like to thank those of you who participated remotely in the public session. Apologies for any technical difficulties up front where we may have had some auditory problems. Hopefully we were able to get the meeting on track for all of you to be able to follow along, and you found it as worthwhile as we did. Thank you.